Мендельсон, правда, Мендельсон. Я так понимаю, в честь какого-то другого, видимо, Мендельсона назван зал. И сегодня мы открываем...
So today we open our conference this conference is devoted to rendezvous process. So we will discuss the aspects of rendezvous techniques with SpyGlass Discover and widening the limits of classical ERCP. And so we'll make something like a round table here. And so we'll get acquainted and soon we'll start. And also we'll switch to Dr. Budzinski, who almost finished his operation and will join our meeting. So now we live in complicated time, and that's why we appreciate good remained relationships between us and our colleagues and companies. So we will make some discussion. Professor Neuhaus is in Düsseldorf now, and now we will see his lecture about Discovery system. Please, dear Horst, now we are eager to switch on your lecture. We are on live here, so everybody can see our conference who joined our meeting by internet. So we'll spread all the limits, not only ERCP.
Welcome, everybody. My name is Horst Neuhaus from the Evangelische Krankenhaus in Düsseldorf, and it's a great pleasure for me to participate in this very interesting satellite symposium. And I would like to talk about new techniques for percutaneous transhepatic cholangioscopy, which may not be so frequently used in your country, and it's also in Western countries and in Germany, it's limited to a few centers. But with percutaneous transhepatic cholangioscopy, with PTCS, we can solve challenging problems that are not amenable to ERCP. So it's strongly recommended to work together with an experienced radiologist or to get yourself experience with PTC. And you can now display my presentation, which shows more details and the introduction of a new single operator cholangioscope SpyGlass. And I'm also grateful to Boston Scientific for supporting this satellite symposium and for the very convenient and fruitful collaboration. So please display my videos, and I'm happy to answer questions and to discuss after my talk.
My name is Horst Neuhaus from the Evangelische Krankenhaus.
Нам нужно погасить свет в зале, иначе аудитория ничего не
I
увидит.
would like to
Или
thank
здесь
the
у нас
organizers for
экраны.
inviting me to this very interesting and important satellite symposium. I would like to talk about novel
Ребята, мы не слышим звука
single operator
выступления Хорста Нойхауза, хотя видим, что он уже
I
говорит.
discuss with you percutaneous transhepatic cholangiography, PTC, PTC-guided drainage and interventions, percutaneous transhepatic cholangioscopy, the PTCS, in terms of indications, biliary approach, and conventional endoscopes. And finally, to focus on novel single operator cholangioscopes. The indications for PTC are seen in patients in whom a biliary access fails by means of ERCP due to a difficult papillar or inaccessibility of the papilla or a biliodigestive anastomosis. Other indications are seen in cases with biliary stenosis or filling defects or stones that are not amenable to ERCP. The pros and cons of PTC should be always balanced against an EOS-guided approach. How should PTC be done? In all of these cases, we recommend MRCP as a first step for showing the biliary tree and choosing the optimal direction for the percutaneous access. Then we have to decide on the right or left side percutaneous transhepatic puncture of an intrahepatic bile duct with an 18 to 22 gauge Shiba needle under fluoroscopic and or ultrasound guidance. We inject some contrast for opacification of the biliary system. Here's an example in a patient with a stenosis at the level of the papilla shown by MRCP. So we decide for a right-sided approach. We use the Shiba needle as shown here, puncture from a right-sided approach, and we inject a little bit contrast, so we can do it just under fluoroscopic control and inject contrast during we slowly withdraw the needle. Or we puncture under ultrasound guidance and then we inject contrast to identify the anatomy. Next step is to advance the guide wire through the Shiba needle, provided that it is in a good position for a subsequent placement of a drainage catheter. It should be not too central, because then we have to consider a high risk of bleeding. And it should be appropriate in terms of the best angle for cannulation and finally placement of a catheter. Otherwise, we leave the Shiba needle in place and do a second puncture of a selected bile duct with an 18 gauge long well needle with an outer sheath. Then, after successful puncture of appropriate duct, we remove the needle and advance the guide wire. Finally, the sheath can be manipulated using a hydrophilic guide wire for crossing the stricture and the papillar or biliodigestive anastomosis. So these procedures are usually done by radiologists, but in some centers, as in ours, it's performed by gastroenterologists, and we have a lot of experience for these percutaneous interventions. This is an example here. The yellow needle shows the position of the Shiba needle. We see some contrast, and then we select an appropriate duct here in the right anterior lobe with a long well needle, blue arrow. We puncture the duct, and then we remove the needle and advance a hydrophilic guide wire through the sheath of the long well needle. And finally, we manipulate the tip here of the angulated wire and can pass the stenosis at the papillar, and cholangiography also shows here an impacted stone. So we try to advance the guide wire here into the duodenum, or in patients with the biliodigestive anastomosis, usually into the jejunum. Finally, we exchange the hydrophilic floppy wire against the stiff guide wire over a sheath. And then we dilate the tract by bouginage and place a 7 to 10 French external internal drainage catheter as shown here. So we see the tip is now in the duodenum here, and we have an appropriate drainage. We also check that there is no biliovenous fistula, and we see no blood coming from the catheter. So this is an appropriate position of an external internal drainage catheter. An example in a patient in whom ERCP failed due to a difficult papilla, 29 years old female patient who previously underwent laparoscopic cholecystectomy. Then biliary leakage was identified after surgery, and drainage was done through a percutaneous catheter. So the position was in the gallbladder bed after cholecystectomy. MRCP showed an impacted distal common bile duct stone and leakage of the cystic stump. The patient was referred after 2 failures of an ERCP-guided biliary access, including pre-cut after pancreatic duct stenting. And ERCP was repeated in our institution, showing an edematous papilla, and we failed again to access the common bile duct even after extension of the pre-cut. So MRCP shows the stone here, the leakage at the cystic duct, and the yellow arrow shows that we now puncture the right biliary tree in the right liver lobe, and you see that the bile duct is not very much dilated, so an EOS-guided approach should be considered, but may be difficult because of the narrow duct, which is not really dilated. So the red arrow shows the leakage here at the cystic stump, and the blue arrow shows an impacted stone. And we were able to place, as I've mentioned before, a percutaneous transhepatic catheter in the first step. So this allows a rendezvous maneuver. So we did an ERCP on the next day. You could of course also do it in the same session, but this would have been quite time consuming. So the next day we advance a guide wire through the PTCD catheter, as shown here, PTCD here. We advance the guide wire, remove the drainage catheter, grasp the guide wire with a snare and pulling it through the accessory channel of the duodenoscope, and finally we can remove the PTCD catheter. Now we have a stable track and stable access from the endoscopic route. We did a sphincterotomy, papillary balloon dilatation, stone extraction with the ERCP balloon catheter. We placed the biliary double pigtail stent and extracted the surgical drainage catheter and the PTCD catheter. So the stent was left in place because of the leakage of the cystic duct, which will close within a few days. So this has been a quite successful procedure requiring a percutaneous access in combination with ERCP. And we can do a variety of other percutaneous interventions. In particular, we can place stents. This is a patient here with a bismuth type 4 stenosis due to recurrence of cholangiocarcinoma after VIP resection, so with a biliodigestive anastomosis, and it would be very difficult to access the anastomosis by means of enteroscopy with a double balloon or spiral enteroscopy, and to achieve drainage of the anterior posterior and left level, but this can be done via the percutaneous route. And for these interventions, we don't need the rendezvous technique, but we can place the stents, as we can see here, with 3 axes, two from the right side, 1 from the left side. We place the self-expandable metal stents, which were advanced over the wires into the jejunum, and finally they can be sequentially released and achieve a complete biliary drainage in a side-by-side position. So very effective percutaneous interventions. Now, what are the indications now for percutaneous transhepatic cholangioscopy? We need, of course, the percutaneous access, as I've explained before, and we have to discuss when do we need a direct visualization of the biliary tree. And these indications are seen in cases in whom we need an advanced diagnostic approach and or therapeutic interventions. And some examples: evaluation of indeterminate biliary stenosis or filling defects, mapping of intraductal tumor extension, lithotripsy of biliary stones, approach to intrahepatic stones, targeted cannulation of strictures, removal of migrated stents or foreign bodies. We can even do an antegrade sphincterotomy, and we can treat ductal tumors either by resection or ablation. Of course, in all of these cases, we selected patients in whom ESCP had failed, because there's no doubt that the percutaneous approach is more invasive. Now, how to get access to the biliary tree for cholangioscopy? There are 2 different techniques. The single step approach means PTC, biliary access, as I had shown before, serial tract dilatation to 16 French in a single session, and then advancement of a cholangioscope through a peel-away sheath for bridging the immature tract, because we don't have a major tract between the liver and the peritoneal cave and the skin or the abdominal wall. And then we place a drainage catheter after PTCS to protect the immature tract. This is, of course, required, because when you remove all catheters right after the procedures, then you have, of course, the risk of biliary leakage. And therefore, we should consider we have a higher morbidity of a single session dilatation compared to interval dilatation. And finally, the time saving is limited, because we need, as I've mentioned, a drainage catheter after PTCS. And therefore, at least in our institution, we usually decide on a single step approach only in quite rare emergency cases. And this is an example here what can happen when you dilate too fast. This is a video showing a large biliovenous fistula. So we have a percutaneous catheter which was placed after rapid dilatation of the percutaneous tract. We inject contrast, and you see the rapid disappearance of the contrast in the venous system. This can be treated by bridging the side of the fistula, which is here, with a catheter that has no side hole at the side of the fistula, so that the fistula is completely sealed. And when you leave such a catheter for a few days, then it's usually stable, and we have a fibrinous closure of the fistula. in case of an arterial fistula, we usually need a radiological intervention with embolization. As I've mentioned before, we usually decide on a sequential approach. This means serial tract dilatation to 14 to 8 up to 18 French, depending on the type of the cholangioscope, in 1 or 2 further sessions after initial placement of an 8 to 10 French catheter within 1 week. And then PTCS can be done by direct insertion of the cholangioscope through the major tract at earliest 7 to 10 days after the initial PTC. And this small video shows that we inject now contrast through the so-called sinus tract to the fistula with the proximal end at the skin. We inject contrast and there is no leakage. The contrast directly flows into the right hepatic duct, into the biliary tree. And the advantage of this technique is that we need a post-procedure drainage catheter only in case of an incomplete internal biliary drainage. And otherwise, sometimes for planned reinterventions or as a placeholder for treatment of benign biliary stenosis. But otherwise, for example, after removal of a bile duct stone and with no association of a stricture, we just remove all catheters after PTCS and the fistula will close within 24 hours. For conventional PTCS, we use cholangioscope, which is video-based imaging, 35 to 7 centimeter in length. In fact, you can also use a bronchoscope, which is a little bit longer, two-way angulation system, and most of the cholangioscopes have a diameter between 4.8 to 6 millimeters, meaning that we have to dilate at least to 16 French. And these devices provide a 2.0 to 2.6 millimeter accessory channel, allowing passage of guide wires, biopsy forceps, lithotripsy probes, baskets, forceps, balloon dilators, or APC probes. This is an example here in a patient in whom ERCP failed due to an inaccessible biliodigestive anastomosis, with a stricture of the left hepatic duct, red arrow, and intrahepatic stones, yellow arrow. We did a PTCS after establishment of a major epigastric left side percutaneous tract. We did introductory lithotripsy with laser. As you can see, we removed the stone fragments through the biliodigestive anastomosis. So this is the site of the stricture after dilatation, after stone removal. As you can see, the cholangioscope is here in a prograde position towards the segment periphery of segment 2 to identify and to fragment stone. And we can keep the track by insertion of a 16 or 18 French transhepatic prosthesis with an external stopcock as shown here. And this provides internal biliary drainage and is used as a placeholder for prevention of stricture recurrence. The same principle as we do for ERCP. In postoperative strictures, we place several plastic stents, and this can be also done by insertion of such a large bore transhepatic tube. So patients flush it once a week, and it's not very disturbing to have such a tube, and this allows an easy re-intervention. And this is also, for example, useful for patients with hepatolithiasis with multiple intrahepatic stones and rapid recurrence. We can easily re-intervene. Now, SpyGlass Discover has a huge impact on PTCS. This is a new, short, single-use cholangioscope, which is in principle quite similar to SpyDS, what we use for ESCP. It's a fully integrated system with plug and play, so very easy to install and to get it ready for interventions. It has a CMOS video technology, 2 LEDs, 4-way deflection, and a dedicated irrigation and aspiration connection. The distal tip width is just 10.5 French. So that means we don't have to dilate to 14 or even 16 French. Usually 11, 12 French is enough to insert this ultra slim scope. And due to the short working length of 65 centimeters, it's very easy to manipulate and to target indeterminate lesions, for example, or stones or other areas for therapeutic interventions. This is a video of the first clinical case in an altered anatomy in a patient with a biliodigestive anastomosis. And as you can see, we take it out of the package, and it's now very easy to set the system up, to get it ready. We just push the plug into the controller, and this patient has a tube in place with a large stone in the common bile duct. The patient who had a previous gastrectomy, and we failed to access the papilla. So we remove the 12 French catheter. So we establish a sinus tract within 7 days. And as you can see now with a 4-way deflection system, it's very easy to angulate and to manipulate and to flush it very effectively. So we don't need a sheath with this sequential approach, but insert the tip directly into the right hepatic duct. So we are now at the hepatic confluence. We have already seen the stone in the common bile duct. But to exclude stones in the left system, we pass the confluence, enter segment 2, inject some contrast, and we can even retroflect into the anterior lobe. And this sequence shows that we can really access all biliary segments. And now we approach the stone, and we still have contrast, but this is the advantage of SpyDiscover. We can flush and at the same time suck and use vacuum for decompression, and therefore we can get rid of contrast very quickly, and we can also decompress the system to avoid high pressure, which would probably increase the risk of cholangitis. And as you can see, we insert EHL probe of the autolit system, which is also provided by Boston Scientific through the 1.2 millimeter working channel. And as you can see, under continuous irrigation, we can very effectively fragment the stones, and we don't pull them through the sinus tract, but we always try to push them here through the papilla into the duodenum. We can also find residual fragments in the central part, can be grasped with a basket, and we can extract stones through the stable sinus tract. This is an alternative, what is only used in patients with intrahepatic stones in whom it's difficult to get rid of all stones by pushing them through the papilla. So finally, we still see some narrowing at the side of the papilla, so we finally did a balloon dilatation of the papilla. Another case, quite complex, 21 years old female patient with a Tudani type 1C of bile duct cysts, and she was operated at the age of 2 years with a radical resection of the biliary cyst and followed by hepaticojejunostomy and a Roux-en-Y anastomosis. She was admitted after recurrent epigastric pain for 4 years. Although the laboratory parameters were normal and transabdominal ultrasound showed intrahepatic stones in dilated bile ducts. And this is the MRCP. And as you can see, the red arrows indicate huge stones in the right and in the left hepatic duct and stenosis of the hepaticojejunostomy. So more or less complete filling of the central bile ducts with stones, but we also see some filling defects in the periphery in both liver lobes. So very difficult to manage. Undoubtedly, this cannot be approached by ESCP because of these huge stones. Even if you can access the biliodigestive anastomosis by enteroscopy, you would fail in removal of these huge stones that need lithotripsy. So therefore, we decided to proceed to PTCS with SpyGlass Discover. So on day 1, you see the PTC with the technique I've mentioned before. The yellow arrows indicate filling defects due to stones. There is no blood. These were stones, more or less in the completely filling of the right hepatic duct and the periphery of the right side, and the green arrows stones in the left hepatic duct. So we placed the 10 French catheter in the first step on day 6. We placed the 12 French catheter, red arrows, tip in the jejunum. And here you can see the huge stones in the left hepatic duct and stones in the right hepatic duct. And on the next day, on day 7, we inject contrast and we remove the percutaneous catheter, leaving a guide wire in place, more or less as a pathfinder to identify the direction to the biliodigestive anastomosis and to the jejunum, which is helpful in such a case because otherwise may be difficult when you have so many stones that you lose the way. And as the video just showed, very effective irrigation, which is important for fragmentation and for flushing. But as I've mentioned before, we can also suck and decompress. So we see a lot of stones and we decided to identify the left hepatic duct, then to pass the scope through the biliodigestive anastomosis, which is here. This is the hepatic confluence. And the first step was that we access the stones in the left liver lobe. So I'm inserting the EHL probe. You see the tip is at the junction of the left hepatic duct with the common bile duct. So see the tip of the EHL probe under fluoroscopy. But contrast injection shows complete impaction of the stone. Even contrast did not pass to the periphery of the left liver lobe. And we fragment the stones. Then we pull the scope a little bit back. Continue with flushing, and then the fragments come from the periphery of the left lobe into the common hepatic duct. And the same technique I've shown in the first video, we push the fragments through the biliodigestive anastomosis into the jejunum. Again, confluence, and now clearance of the left side. No more stones. We've seen the junction of segment 2 and 3. And now we focus on treatment of the stones in the right liver lobe. And once you get rid of the large stones in the central parts, then it's quite easy to flush the small fragments from the periphery into the central parts, and also to push them through a biliodigestive anastomosis or papilla. So we have a look into the jejunum. This is the stump of the jejunum. See, a lot of small fragments remained. But you see no more filling defects in the periphery. We pass the scope through the confluence here, still at the side of the confluence, no more larger stones. This is the final fluoroscopy. And then we place the percutaneous transhepatic tube, as I've mentioned before. It's very flexible. We advance it over the wire. It's blocked at the skin level, and as I've mentioned, patients flush it once a week, and this keeps the tract open because we want to assure that no residual stones will remain. And patients came back after 5 weeks, and we repeat holangioskopy using SpyGlass Discover. Right hepatic duct, you see just some biliary sludge, and this is a junction from the right liver lobe into the left liver lobe, segment 2 and 3, and then we pass the scope into the common hepatic duct and through the biliodigestive anastomosis. You see no more stones were left, and this is a final control. And the advantage of having a stable track, we could remove the catheter and the fistula closed within 1 day. A special case, a final case, 71-year-old male patient who underwent Roux-en-Y anatomy after gastric resection because of gastric cancer. several surgical re-interventions were required. In 2018, he underwent endoscopic enteroscopy, ERCP, sphincterotomy, and implantation of a biliary plastic stent. Stones were left in place. And in December last year, he was admitted with jaundice and cholangitis, and MRCP showed that the stent migrated upwards. And PTCS was done because another endoscopic approach failed to remove the migrated stents. You see multiple large stones, and the stent was somewhere here in the common bile duct. And this was done at our recent international symposium in February this year by my coworker Gerges. He already removed the huge stones, as I've shown before, with SpyDiscover. He pushed the fragments through the papilla, and he could now grasp the impacted stent with SpyBite Max with a large forceps, which we use otherwise for biopsies. But it was impacted, he could not grasp it. Finally, he used the snare, and he was able to grasp the distal end of the prosthesis with the snare and pulled it through the sinus tract. And again, he didn't need another drainage catheter because he could finally remove both stones and the stent. I would like to conclude, PTC and PTC guided drainage are very effective for achieving biliary access in case of failed ERCP or ductal strictures or stones not amenable to ERCP. Serious adverse events are more frequent compared to ERCP. They are mainly related to the initial drainage procedure and subsequent tract dilatation. Some are life-threatening and require advanced interventional radiological expertise, for example, embolization. An US-guided approach should be considered as an alternative procedure depending on the individual anatomy, indication, and local expertise. PTCS cholangioscopy offers a large variety of diagnostic and therapeutic biliary procedures that are not amenable to a per-oral approach. It's safe after establishment of a major percutaneous tract, and PTCS with SpyGlass Discover offers advantages over conventional cholangioscopes, mainly because of limitation of tract dilatation to 12 French gauge, a four-way deflection, improved maneuverability, and also a very effective irrigation and suction capabilities. I would like to thank you for very kind attention, and if you're interested in these kind of procedures or other advanced endoscopic procedures, I would like to invite you to our next, the 25th Düsseldorf International Endoscopy Symposium, which will take place from February 2 to 4 next year. Thank you very much again, and I wish you a very fruitful and enjoyable and interesting conference. Thank you.
Давайте попробуем поаплодировать, чтобы он нас услышал. Horst.
So, Horst, we applaud to you. I don't know if you hear it or not. Thank you very much. Thank you for your very accurate and very well illustrated lecture. So Professor Fedorov speaks, and I translate for you, Horst. So, if possible, several questions. So, we are very thankful to you for joining us. So now we collect some questions for you here. So we know that in your clinic there is a lot of contemporary techniques with endoscopy, is spiral colonoscopy, and difficult endoscopic interventions, intrahepatic intervention, and you have a lot of techniques. But if we speak about ERCP, and you have all the variants and all possibilities, endoscopy, EOS-guided, and transcutaneous approach. And if you take into account cost, effectiveness, and patient's best choice, how do you choose the technique when you have to do a complicated intrahepatic intervention?
Of course, on the individual case. So in patients with an altered GI anatomy, for example, with Roux and Y anastomosis or difficult B2, we always try firstly enteroscopy to approach the papillar or the biliodigestive anastomosis. But it depends on the MRCP, which should be done if it's available before. For example, in the case I've shown with a young patient with multiple intrahepatic stones, it would be very, very unlikely that you achieve a complete bile duct clearance with ERCP in an altered anatomy. So this might be an exception that we primarily proceed from the percutaneous transhepatic approach. But otherwise, always ERCP is the first step. And if we cannot reach the papillar or biliodigestive anastomosis, or if we fail in cannulation, which is quite rare with advanced techniques, pre-cut and so on, then the EOS-guided approach would be the next step, because also the randomized control trials show that the EOS guidance is safer and as effective as PTC. But it depends, of course, on the individual case. For example, in patients with an hilar cholangiocarcinoma, a Klatskin tumor, where in whom there are difficult stenosis on the right liver lobe, they cannot be accessed via EOS guidance. But let's assume a patient has a bismuth type 3 or 4, so strictures on the left and then right hepatic duct, then again ERCP is the first step. And if we fail to decompress, to drain the left liver lobe, then we do the combination ERCP for drainage of the right side, and if needed, then the EOS-guided hepaticogastroscopy on the left side. So PTC only if these interventions fail. But frankly speaking, in advanced hilar cholangiocarcinoma, in 20 to 30%, you need also percutaneous access. And this, I think, are patients who are not so often mentioned because they're treated by radiologists, but we should be fair to say that we need in advanced tumors also the percutaneous approach.
Большое спасибо за, как всегда, очень четкий и понятный ответ. Тема нашего сегодняшнего симпозиума.
So, today we also will discuss our rendezvous techniques. So, what experience of rendezvous do you have in case of total cut of bile duct? Like iatrogenic defect, when a bile duct is cut into two separate portions, proximal and distal. So do you have an experience to combine cut ends of bile duct with rendezvous techniques?
Yes, we have. These are, of course, rare cases, but this can be done by a percutaneous access. And for example, to establish a track to proceed to holangioskopy, preferably with SpyGlass Discover. And then we approach the stump of the dissected duct from the upper side, from the proximal side, and then we do ESCP at the same time, so in this combined procedure. And then we can use a needle or a knife to cut when we see the light shining through the duct. Then we puncture either from the percutaneous route or from the endoscopic route. We puncture to achieve a connection between the dissected duct and insert a guide wire, and then the guide wire can be pulled through the track, and finally a stent can be inserted to establish the connection.
Спасибо большое, в том числе за такой расширенный ответ.
Thank you for very detailed answer, for going into such interesting details. And now we have more easy question. So you showed very nice lithotripsy cases. And what do you prefer, laser or electrohydraulic lithotripsy? And do you see any difference between these two techniques? So, for example, if we have clinic who want to buy some lithotriptic device, would you recommend laser or electrohydraulic?
You should join your colleagues from the Department of Urology. So if they have a laser, a holmium laser, for example, then you can share and use the machine also for the endoscopic interventions. Otherwise, it's probably too expensive to use it only for endoscopic procedures. And EHL is much less expensive, and the effectiveness is quite similar. The fragmentation is different. The laser takes usually more time, even if you use it with high power, and fragments in very small particles. And the EHL is faster, fragments in bigger particles. But in case of big stones, we need sometimes several probes for complete fragmentation. And the procedures have to be done under continuous irrigation. So I don't think there is, and also there is no study to show that there is a difference in terms of the effectiveness. Safety is probably also the same. These procedures should be done under direct visualization, preferably with SpyDS for the ESCP or SpyGlass Discover, as you have seen for the percutaneous route. You can use both devices, and if you do it under visual guidance, then the risk of bleeding or perforation is more or less zero. So bleedings always stop spontaneously, and I've never seen a perforation when it's been done under cholangioscopic guidance. These are the main differences. We used laser for many years. The disadvantage is, especially when we use SpyDS and also now SpyGlass Discover, which are excellent cholangioscopes, and as I've shown you also in the video, they can be nicely angulated to get the tip of the scope into the different radicals of the intrahepatic system. But when the tip is angulated, then it may be difficult to advance the blank laser fiber through the instrumentation channel, because the tip is quite sharp and it may break and you cannot advance it through the channel. And from this aspect, the EHL probe is easier to insert to the cholangioscope. This may be an advantage. So if an institution would like to start with fragmentation and cholangioscopy, I think for most of the cases I recommend to acquire EHL instead of laser. Only when you have already laser in the urology department, then you can share.
Спасибо большое. Если позволите...
And so one more question. We expect from our surgeons who operate patients who operate bile duct diseases, they will stay for development of holangioskopia, especially for bile duct stone as a topic of your lecture. And the question is about oncologists, and it seemed that they will be happy to obtain biopsy from tumors of bile duct. So please, could you tell a few words about tumors, bile ducts, and holangioskopy?
Recommend, and I think it's really necessary to do an MRCP first to show the anatomy and the extension of and location of stenosis. And then in case of an ERCP access to the biliary tree, I directly start with cholangioscopy with SpyGlass to see the untouched biliary tumor and stenosis. So when you dilate before and do buginage and you place a stent, then you cause, of course, changes of the mucosa and bleeding and so on. And it's very difficult to differentiate between inflammatory changes and a tumor. So I insert the cholangioscope, SpyGlass, or from the percutaneous route, SpyDiscover. Then we can take biopsies under direct visual control and do a mapping. That means we insert it into the left and right hepatic duct and even to stenosis which are located in the different segments to decide on the intraductal tumor extension. And there is sometimes a discrepancy between MRCP and ERCP and cholangioscopy. With cholangioscopy, you can precisely determine the intraluminal spread, and this is important. For example, when you have bismuth type 3A, so stenosis on the right level lobe, and just the involvement of the left hepatic duct, then it's very important for the surgeon to know is it type 3A. This would then be a candidate for extended right hemipatectomy for curative resection of a cholangiocarcinoma. Or is it already type 4? That means if the tumor is already involving the segment 2 and 3 of the left level lobe, then curative surgery is no longer possible. And therefore our surgeons would like to have cholangioscopic evaluation before major surgery and resection. So therefore the advantage of cholangioscopy is three times. Firstly, taking biopsies under direct visual control. This is more effective than to do it under fluoroscopy because we know exactly where to take biopsies. We can angulate the tip of the cholangioscope to, it's like in the esophagus, to push it against the wall to get larger specimen. Secondly, we determine the interluminal tumor spread. And thirdly, we can cannulate difficult strictures. For example, when we fail to cannulate the left hepatic duct or the right anterior lobe, or from the percutaneous route, if we cannot cannulate the biliostenosis at the biliodigestive anastomosis, then we can target the site of the stenosis with a cholangioscope and insert a guide wire under direct visual control, which is very effective. And in addition, you have much less radiation exposure.
Спасибо огромное. Юлия Валерьевна, ваши вопросы?
Thank you very much. Now we give speech to interventional radiologist, and a question about lithotripsy. So the question is about some details. When you do percutaneous lithotripsy in bile ducts, how do you push the fragment stones to the duodenum or small intestine? Do you prefer do balloon dilation or sphincterotomy or what else?
Yes, usually we already have the stable tract, the sinus tract, which I mentioned. So PTCD catheter, first step is what we do to place an 8 or 10 French catheter for external internal drainage. This is the first PTC intervention. Then after 3 or 4 days, we exchange the drainage catheter to 12 French. And then after 1 week, we have a stable tract so that we can insert Discover directly into the biliary tree. When there is still a stenosis at the level of the papilla or of the biliodigestive anastomosis, for example, hepatococcygeostomy, then this is important. Yes, we dilate with a balloon because then it's much easier to push the fragments through the papilla or through the anastomosis into the duodenum or the jejunum. So we flush and push with the tip. This is much faster than to use a basket and to extract what is possible with SpyDiscover, but it takes time to remove all the stones through the tract. And when we have patients with intrahepatic stones, which is always quite impressive, for example, if we have stones in the left liver lobe and we're coming from the right side, then we fragment the stones and then we flush and pull the scope back. And because of the higher pressure upstream of the stones, all the fragments come towards the left hepatic duct and the central part of the bile ducts, and then they can be advanced into the jejunum.
Thank you very much. And one more small question. And do you use introducer when you work in intrahepatic ducts to prevent hepatic trauma with stone extraction? Do you need some overtube or introducer for SpyGlass to prevent hepatic duct trauma?
This is only needed in case of a single approach. When you place a PTC catheter and you dilate in the first session to 12 French to access with SpyDiscover in the session, then of course you need a sheath because otherwise you have a leakage and you have not a stable connection with the abdominal wall or the thoracic wall and the liver. But we use it quite rarely because finally you have to leave a catheter after intervention, because when you remove the catheter after stone extraction, then you have the risk of a bile leakage. Therefore, we prefer what I've mentioned before, the sequential approach. So usually within 1 week, we have a stable track, and then we don't need a sheath. Then we can directly insert the scope. And we don't damage the track because we don't, as I've mentioned, usually we don't pull the fragments through the track, but we push them internally. So then we don't need a sheath.
Спасибо большое.
Thank you very much. So the audience is very thankful to you for so detailed answers and questions from audience. So if you have a proximal biliary block, and you, as far as we could understand, try to start endoscopically to do it. So what's the effectiveness of this approach? And how do you see the effectiveness of SpyGlass with overcoming strictures with guide wires under direct control? So what's the effectiveness of these different techniques?
As I've mentioned, and then with using sphincterotomes and angulated wires and injection a little bit contrast to identify the anatomy and the site of the stenosis. And then we can usually guide the tip of the hydrophilic guide wire through a stenosis. With the sphincterotome, we have the advantage we can bend it, so we can change the direction of the guide wire. With an angulated wire and a torque, we can rotate the tip of the wire, so we can pass, I would say, at least 90% of the stenosis. But when we fail and we have to, we would say after 10, 15 minutes or so, it's also a lot of radiation exposure. When we fail, then we use SpyDS to identify, to have a direct visualization of the stenosis, and then we pass the wire through the SpyDS and through the stenosis, which is usually very effective. So if the ERCP approach fails, then, as I've mentioned, you can try an EOS guided via the hepaticogastrostomy from the left liver lobe, or the percutaneous route. With the percutaneous access, I would say we can pass just with PTC techniques because of the short distance and using wires and special also bended catheters. We have a lot of possibilities to manipulate guide wires. I would say in 98% we can pass even difficult strictures. In rare cases, when we cannot pass the guide wire through the papilla in case of a very tight stenosis or biliodigestive anastomosis or intrahepatic stenosis, when everything fails, then we leave percutaneous catheter, and in the next step we use SpyDiscover also to perform holangioskopy, and then to pass usually eccentrically located stenosis with a guide wire under direct visualization.
Horst, еще раз благодарим вас. Нам жаль с вами расставаться.
So we are very thankful for you, and it's really pity when we finish our communication, because it's a real pleasure to listen to you. And so now we have to move forward, and now we give an opportunity to say a few words for our radiologists who work in Moscow Scientific Center and specialist for interventional radiology. So in Russia, interventional radiologist is a X-ray surgeon, so-called. And so it is very experienced specialist for invading any ducts, despite of diameter and location. So, so a few words about holangioskopia and integrated approach. So here audience is mostly endoscopists, and despite of that we speak about percutaneous approach. And so the indication, as Professor Neuhaus told, is a impossibility of any other approaches like endoscopic and so on. So the benefit of integrated approach is a shorter instruments, shorter devices. That is why maneuverability in force and other aspects are mostly more effective. So our technique is similar to that Professor Neuhaus told, but we made it more continuous and normally start to do some cholangioscopy and other interventions not earlier than after 2 weeks, because we want to be sure that the new formed duct between skin and bile ducts is firm enough, and that is why like a cholangiostomy of safety, so-called, we usually left for 2 weeks. And we are very in charge of predicting or treating such complications like cholangitis and so on. And of course, we perform this intervention under intravenous or other type of anesthesiologist help. And so when we speak about literature review, there is some most important tasks for it. Firstly, for diagnostic field, this is many tasks like diagnostic of biliary cysts, difficult strictures, different tumors, and so on. But the most important is strictures and is benign and malignant differentiation. And so obtaining of biopsy is very important. So we work with classical tumors, and it is very important to obtain morphological specimen for it, to administer proper therapy, whether it's chemotherapy and so on. So when we want to diagnose classical tumors, we want to do it with integrated approach. So you can see images familiar to you from previous lecture. So we usually invite cytologists in our operating room and do on-site cytology. And if we've got enough material to make the diagnosis, then we finish procedure. And if it is lack of material, then we try to do biopsy from other parts of strictures to obtain enough material to get the diagnosis. And of course, here we need to have the qualified morphologist or pathologist, because it is the very important for this procedure. We will nothing do without them. Also, when we speak about the literature, if there is a proximal stricture, then integrated approach is much more effective for biopsy than retrograde approach. But if we have a distal strictures, then ERCP look to be more positive and effective than percutaneous approach. So if we have a lack of information from any other techniques when we do antegrowth approach, and also if we have some complications of previous intervention, and it is a possibility with antegrowth approach to manage them. And of course, also, when we do video holangioskopy, then it is a high chance for us to do a precise biopsy. Here is the video case with the SpyGlass. So here you can see the tumor in the bile duct, intraluminal tumor. If we do a blind biopsy from this tumor, there's a high risk of bleeding, according to our experience, and that is why we do visualized control biopsy of it. Then let's speak about therapeutic tasks. Of course, this is a bile duct stones. You saw how good it can be done with undergrad endoscopy by Professor Neuhaus. So intrahepatic bile ducts, of course, the main reason for it is a biliary lower stricture. So also patient operated by different RU anastomosis. It is so-called anti-endoscopic operation. And of course, endoscopic approach after different biliodigestive anastomosis or altering the anatomy, of course, and in case of cholangitis, in this case, endoscopic approach is almost impossible. So it's good to do antegrade approach. So there is lots of publication about antegrade cholangio-lithoextractive techniques. We've got literature from 1990s, almost more than 30 years. So that is results of Italian study group. There is an indication for antegrade stone extraction. And one of the indication is that stones impossible to remove by ERCP because of difficult anatomy, like diverticular, some papillary disorders. Stone extraction was not so popular, but antegrade lithotripsy was very popular. So we've got 16 patients with biliodigestive anastomosis. So we usually postpone the procedure for 2 or 3 weeks, and we want a wide approach with for the endoscope with a wide channel. So sometimes we apply bougie after cook up to 24 French. Sometimes we bougie this with the guide wires, and we do it for a long time. That's the reason why we do it after 2 or 3 weeks of preparation. And then we introduce the wide scope with wide instrumental channel. And here we do the second approach, as you see the cholangiogram, because dorsal ducts have their own confluence. And now you see that investigate the ducts. You see the guide wire, and so we manage stones for this problem. And as we have a 24 French overtube, and we can extract almost stones of any diameter. Thank you. So you see that there's different stones. Several times we use contact laser lithotripsy, the green laser. You see how we destroy stones. So you see that here is the very wide bilodigestive anastomotic fistula. So it's like a film, Star Wars, lots of lasers. Also, we've got an experience with managing a migrated plastic stent. So here you see the area where the plastic stent was stuck. So when we formed the approach, then we took a snare and removed the stent. Sometimes we extracted foreign bodies with this devices. We had 2 cases of severe bleeding. But we use a mechanical way to manage it. We just pushed it with the scope, and everything was okay after several minutes without any complications with the patients. The main problem for us as X-ray surgeons is bilodigestive strictures. We had more than 20 patients, and 18 cases we failed to do it with X-ray techniques. And 2 patients were reoperated by surgeons. They were like neo-anastomotic operations. And so you see how we did it, how we did some re-anastomotic operations. You see, it's almost obliteration of the duct. We could insert the wire, and with the needle knife we burnt the orifice, and then after insertion of a guide wire, we did it in a familiar way with the dilation and so on. In 2 cases, we did new neo-anastomosis using sonography. And as you see, we dilated bile ducts and channel percutaneous even more to make possible and linear scope, echoscope insertion, and then we find a new place for doing reanastomosis. So some kind of timing problem with this patient, because there's several steps. We have to hospitalize a patient several times. And that is why there's a question of a kind of positive. Then if we take SpyGlass, then we will need less widening of approach through the skin to the bile ducts and reduce time and increase effectiveness of procedure. So there is a Chinese data with a retrograde and antegrade approach in case of roux anastomotic altered anatomy. And also, if they consider that the channel is going through the pleural sinus, then they extended time of waiting for channel forming, not to 7, but to 10 or 13 days. SpyGlass are very maneuverable. They're very safe, and it is good because they disposal. There's a lower risk of infection. Also, irrigation channel is a strong plus for it, but there are some disadvantages of SpyGlass. Visualization is not so good as a traditional scope. And there is no function of image enhancement, and of course a lower quantity of specialized accessories and instruments. Some slide switching problems. So we have two experience of SpyGlass. This is a patient after laparoscopic cholecystectomy, but it was very traumatic and complicated because of very severe cholecystitis. And she had almost all the time with pain syndrome, and we even thought that it was some foreign body left during operation. But after examination, we see that the sixth segment was almost completely obstructed with small stones. And so we resolved the problem with the SpyGlass. So now we'll switch to video. Here's going to be some video. Yes. Now you see the approach to ducts. So some stones flying here. This is an area of stricture. And now you see intrahepatic ducts. So you could see the inner side of papilla. Then we performed stone extraction and extracted almost everything. Then additionally performed EST, and some stones were pushed to the duodenum. And the next patient with laparoscopic cholecystectomy in anamnesis, and they lost some stones in the bile ducts, and there was a recurrence of cholangitis and some hepatic abscesses. And we also did stone extraction with SpyGlass. So you can see the stones here in the cavity. We could find lots of stones with the basket. It's very good that there is a basket for SpyGlass. And also we could not extract it through the introducer of 12 French, so we do it with natively. So there is lots of benefits of SpyGlass because it's maneuverability, rather good imaging, and it's very good that now we've obtained a basket for stone extraction. So it really vastens our possibilities in treatment of such conditions. But we have some question. We really need additional instruments for SpyGlass, like coagulation devices and some knives, because sometimes we want to operate something in bile ducts, like cut the strictures and so on. And they're really expensive, like in our situation, it's almost impossible expensive for us. So we want to find a possibility to make it really cheaper. So a kind of traditional conclusion that if we work multidisciplinary together, like endoscopy surgeons and X-ray surgeons, then we will be able to help each other in different difficult situations. Thank you very much for your attention. So thank you for impressive report, especially I was impressed for intrahepatic bleeding. So now it's the time for questions. And now we switch to our next presentation, Dr. Budzinski. Could you finish successfully your work in operating room? Yes, we could overcome the stricture in operating room. It was rather difficult. So with some technical difficulties, we could overcome it with some fresh ideas. So dear colleagues, we continue discussing the contemporary direction of endoscopy is the question of peroral endoscopic approaches to biliary and pancreatic tree. So this topic is very actual because firstly, patients will often and always suffer from biliary and pancreatic disorders. And if we revise some perspectives, and you see that mostly of new endoscopic approaches, they are connected with visualization. Any new techniques require holangioskopy. And so, unfortunately, I came just now from the operating room, and I am sure that you discussed main aspects of holangioskopy, but I will briefly remind that the historical aspect of these devices that start with mother scope and baby scopes. And it was very difficult, and it required two specialists. And the scopes were very difficult to maneuver, and it was very expensive to repair it. Also, we tried to work with ultra-thin gastroscope and a very good visualization. And a holangioskopy with the nasal scope. It is very difficult to approach scope to the bile duct, and that is why there was a new device after Boston Scientific called SpyGlass. And it was a global renovation recently. And it gave us possibility to do absolutely new and very interesting and very useful things. First of all, it's a very mobile system. So you know that there is two wheels with 4 directions and so on. And so this is assistant-free techniques when everybody can work to the single operator. And some experience required, but it is rather possible to work with SpyGlass with a single operator. But there are some limitations. Of course, that's only for high-volume centers. And if we speak about diagnostics, of course, there's a kind of control of bile ducts and diagnostic investigations. Of course, it's a verification of different complicated bile duct stones. And also, there is a revealing source of hemophilia and some parasites. If we differentiate biliary strictures, you see the sequence, what we have. And also, you see that sensitivity of devices becomes really better. And now you see the difference between DS1 and DS2. And maybe it is difficult to estimate the difference on this monitor, but be sure that the work in the patient is really a big difference. And also our visualization helps to think with a high specificity about what stricture we deal with, benign or malignant. And as you can see, there is data of our foreign colleagues. And so you see that the main characteristics of effectiveness when you do it with the visual control is much better than if you do it blindly. So it is much more effective to do it under visual control than after X-ray navigation. And so you see that now we visualize, so we deal with the concrements and then finish the procedure. Now you see the imaging with verification of different tumors. And also difficult bile duct stones when we see no concrements and stones after cholangiogram, but we see it with SpyGlass. And also we can extract it with the Dormia basket. Also we can diagnose altered anatomy in cystic duct. Also, we could find stones not seen during to X-ray. Also, very important group of patients at bile ducts, stones on the ligatures. We cannot see ligatures in case of X-ray. Ligatures is only for SpyGlass or other visualization. And so any operation on bile ducts, if there's a ligatures and stone formation on it, we will not see it with X-ray. And now our experience shows that if we see patients with lots of recurrent bile duct stones, mostly that is because inside ligatures, according to our experience. So here is like a stone-like stone, but sometimes we can reveal cholecystic fistula between bile duct and gallbladder. So also we can reveal the site of bleeding in bile duct. So this is a rare experience. You see the two images simultaneously, like blood from bile duct. And now you see blood outflowing after EST. So it was cholangiography, and after that we wanted to diagnose the site of bleeding. Then the holangioskopia. And then we see like erosive cholangitis. And one of these ulcers was the source of bleeding. You see that blood flowing. And another case of the right image. A lesion in the first segment of liver with blood through the duct. Later, we switched this patient to angiography in the left video. And there was a fistula with the vessels. And you see angiography data. So in this case, it was not enough just to make the diagnosis, but always to treat anyway. And here you see the area of interest. So it's a very interesting case. And objectively, only visualization could clear the problem. So that was something in the terminal bile duct. And so you see that was a removal of Echinococcus capsula. So we did холангиоскопia, a very unique the image like eosinophilic esophagitis. So patient got a special therapy. So if we speak about therapeutic holangioskopy, it was much told about it today. So it's any operation with visual navigation, also scar strictures, stones, also we can apply it with radiofrequency ablation, and I consider it to be an interesting field is the removal of epithelial lesions. And now I'll speak a few words about stone crushing with electrohydraulic and laser techniques. So if we speak about electrohydraulic lithotripsy, it's rather effective up to 97%. And standard complications up to 10%, like in other techniques. Of course, electrohydraulic lithotripsy is mainly more cost effective. It's rather cheap. If we speak about lasers, so you see that effectiveness is almost same and almost the same complication rate. So we speak about holmium laser. And this technique is rather old, even in biliary. And if we compare different visualization for contact lithotripsy, then the better the scopes, the better techniques, then more possibilities we have. Here you see the comparing between SpyGlass DC1 and DC2. And here the standard parameters like mainly timing of procedure and one more wide estimation between mother-baby system and DS1 and 2 system. And you see that there is a significant decrease of timing of procedure with the later equipment. Of course, better visualization, more effective, and shorter procedure. So everything we spoke about here, this is data of our Eastern and Western colleagues with a very big study group. It is possible to manage different stones with any size, even big ones. The data is similar for transpapillary and antegrade interventions. This is a comparison between the contact lithotriptic techniques and distant shockwave lithotripsy, extracorporeal approach. ESG recommend to switch to contact lithotripsy as the first step, and to switch to distant shockwave lithotripsy when the first steps is not effective. And also here is a new approach, the new laser. This is a totally super energetic laser, firstly approved at 2050s. I remember Italian colleagues crushing the stone in bile ducts. And also we performed pancreatic duct stone crushing with this totally laser. Also, when we perform holangioskopia, sometimes it's very important to remove the basket with stone under visual control. So this is a kind of basket. You see that we can see, we can grasp, we can extract. Also, intervention due to post-operative strictures. Sometimes there can be some clips. We can find clips even with X-ray, but if we speak about ligatures, we can observe them only directly with visualization, but not by X-ray. And so you see that we can manage some strictures. It is very helpful to insert the wire under visual control. That's very positive even for radio frequency ablation. So you see that there are different approaches for holangioskopy. We can do it in many ways, as you can see. Also, there is not so widely spread in our country, but photodynamic therapy also possible in bile ducts due to holangioskopy, as my foreign colleagues shared their experience for this slide. So it is obviously that it is very good to improve life quality for patients with this technique. So we may do holangioskopy for primary photodynamics and for endoscopic control. Also, it is possible to extract migrated stents. Of course, it is always a problem, especially if we deal with migrated state in pancreas. So if we cannot remove the stent with X-ray guidance, then we can try to do it with pancreaticoscopy guidance with special Boston Scientific loop and the loop. And here you see the extraction. Of course, it resulted in pancreatitis, but patient was successfully discharged from hospital with any significant sequences from this pancreatitis. And so we performed holangioskopy in bile ducts, but we saw some epithelial lesion. We did a biopsy and could remove it with the forceps. And so it was hyperplastic biliary polyp. Of course, we should remember about complications of holangioskopy. But complications are very, very rare. So we may consider it a very traumatic intervention, but really amount of really complication rate is not so big. So several images concerning to 2020th year. Now you see the statistics in Europe and in other parts of the world. And there's really a definite percent of intervention require if we have no limits in our equipment. I think that 7 or 8% for holangioskopy is a must. We started doing SpyGlassoscopy from 2017 year, and we have some experience in it. But this technique is still develops in our country. So there is some contraindications. So like any technique, it has its own contraindications. Sometimes they're very logical. If patient is in a very poor condition with comorbidities, also acute pancreatitis without biliary origins, and also uncontrolled disorders of blood, and of course, if we cannot reach a papilla, we cannot perform retrograde cholangioscopy. And sometimes, if we even cannot reach the bile duct due to difficult distal stenosis like pancreatitis, pancreatic tumor with very firm and rigid strictures of the distal part of bile duct. So there is a limitation for cholangioscopy. And so if we speak about further development of cholangioscopy, and so I see that antegrade approach may be really a new field with treatment and diagnostics of biliary tree disorders. And so if we have contraindication because of deformation or altered anatomy with impossibility to approach from retrograde site, then we can perform antegrade approach like previously was told us. We can do cholangioscopy through the skin, like after PCD approach. So you see that we performed cholangioscopy through antegrade approach, treated the patient from this problem. So in the end of it, I see that indications for retrograde cholangioscopy is a complicated strictures, complicated bile duct stones, foreign bodies after previously surgery or endoscopy. So there is a special technique to perform cholangioscopy with the video system. It's not extremely complicated, it's rather feasible. So it is not so difficult, but expensive. It is rather effective according to literature data, according to our own experience. And of course, at the background of low complication rate. And of course, we need to develop antegrade approach. We speak about SpyGlass Discover. So thank you for your attention. If we have time and questions, we can deal with it. Thank you very much. We have no time, but we will find it. This is not a duel. This is rendezvous techniques. It is difficult to find maybe some discovers here. This is a question, the question from far distant area, a question about electrohydraulic lithotripsy. This is a trauma to surrounding tissue with electrohydraulic lithotripsy. If we take laser and if we take electrohydraulic lithotripsy, but mainly electrohydraulic. Of course, we can damage walls, but if we do it under visual control, and we should try, if we do laser or electrohydraulic, if one shot goes into a wall, like a very short, limited strike to wall, nothing will happen. But if we do it more continuously, we will do a hole in the bile duct wall. It was a single experience of perforation in the world. So if we touch If we touch biliary wall with the laser for a short period of time, we didn't observe any changes on mucosa. A question for X-ray surgeon. And so, as X-ray surgeons, we do approach for endoscopists, and our experienced endoscopists usually perform endoscopic approach to liver. We work in a multidisciplinary approach with endoscopists. We do percutaneous approach. And so we always work in team with endoscopists, and we exchange patients, we do work together, and so on. Of course, endoscopists should be happy that even we have Klaskin tumor, it is reasonable to start with endoscopy. So it's reasonable to start with ERCP. If some problems, we switch to EUS guidance. And if we fail with all endoscopy, then we switch to percutaneous approach. So in Russia, how and when we switch techniques between ERCP, randevу, or antegrade approach? Our clinic have a division into biliary confluence. If it is lower when hepatic confluence, then it's for endoscopies. If it's intrahepatic ducts, when we work initially ourselves. Yes, that is why, firstly, we divided our spheres of influence this way, and in all complicated areas, we work together. For example, if ERCP fails to drain some ducts, some hepatic segments, but did the main work, then we may add our force to drain some difficult segments. So, and the answer from endoscopists. We have also some borders. We try to deal endoscopically Bismuth 1 and Bismuth 2, but 3AB and 4, we usually work antegrade with their specialists. But there is a clinical national recommendations. They're based on analysis of our main sense. So effectiveness, complications, and costs. And ESG recommendations not so strict. Of course, there is also a shift then. Some techniques may be chosen in case of what specialist is more experienced in this area, whether it be for undergrad approachers or endoscopists. So, if more questions? A question from a surgeon and came from outskirts from the village. And I take a flexible cystoscope for intrahepatic ducts approach. So the question is, can we take a flexible cystoscope for endoscopic intervention in hepatic ducts? And can we do the same with cystoscopes if we do not have money for this equipment? Also, we have an experience of applying bronchoscope with wide channel, but not holangioskop. So we need to apply proper instrument if it is not restricted. We need diameter and channel. As the same as recommended to take laser from urology department and not to buy second because it is extremely expensive. I think that our meeting was very informative, very interesting, and Professor Neuhaus, we're sincerely thankful for you for outstanding information. We are a bit out of time, but we've got very good information, very good clearance of the data about bile duct investigation and treatment, and it was very important for us. And that is why if we perform holangioskopy, we will see much more interesting diseases, much more interesting conditions. That is why it is a strategic evolution for endoscopy as holangioskopy, and of course we have to develop this field, and then we give the next interest to the next generation to develop these techniques. And we should work together between X-ray surgeons, endoscopists, and oncologists, and abdominal surgeons. So I hope that we will watch for development, expect for development of this. And so if we do biliary surgery, biliary endoscopy, we need to have something to be inserted into bile ducts. Thank you very much for attendance. Thank you. So our meeting is over.